breast. Okay, so hello everybody. Thank you, Rohit, for this introduction. I'm going to speak today about apocrine lesions of the breast. I have no conflicts of interest for this presentation. Well, first of all, this is a short overview of apocrine breast lesions. It's a large spectrum of lesions going from benign metaplasia to invasive carcinoma. I'm going to first of all talk about the definition of apocrine features, and then I'm going to review all these different types of lesions, and we'll end the talk with more molecular side of the apocrine tumors called molecular apocrine tumors. First of all, when you look at the phylogeny of mammals, the mammary gland shares a common ancestor with the apocrine glands of the axilla and the anogenital region. And this common ancestor was a primitive apocrine gland that appeared sometime 250 million years ago in pre-mammalian species, and that it evolved later on towards a mammary gland and hair and cutaneous adnexal glands in the mammals. What about the definition of apocrine features? First of all, when a cell is pink, it's not necessarily apocrine. During the review of the literature for this presentation and for articles, I have noticed that the literature is biased by the inclusion of non-apocrine lesions classified solely on suggestive morphological features without immunohistochemical confirmation of apocrine differentiation. So when you talk of the definition of apocrine features, you must include morphological as well as immunohistochemical characteristics of these cells. Concerning the morphology of normal apocrine cells, they are larger than normal luminal epithelial cells. Their nucleus is rounded, nucleolated, and often basally located. The nuclear size of an apocrine cell is 1.5 times to 2 times that of a normal luminal cell nucleus. The cytoplasm of normal apocrine cells is abundant, eosinophilic, and may contain granules and lipofuscin. This is the type A apocrine cells, the most common form of apocrine cells. There's a very uncommon form of apocrine cells where the cytoplasm is abundant and foamy. It's type B cells. Now, the immunohistochemical profile of a normal apocrine cell is pretty well defined. An apocrine cell is always estrogen receptor negative and androgen receptor positive. Notice that I use the threshold used by the French, 10% of positive cells, for defining positive and negative hormonal receptors. Now, in this slide, as you can see, the apocrine cells are estrogen receptor alpha and progesterone receptor negative, androgen receptor strongly positive. They are also FOXC1 negative and FOXA1 strongly positive. I'll come back to these two markers later on in my talk. They do not express the normal apocrine cells high molecular weight cytokeratins, like for instance here cytokeratin 14 is negative. And as you can see, for the HER2 immunostain, you have this quite peculiar intense granular cytoplasmic staining of the apocrine cells with the 4B5, the Ventana 4B5 HER2 antibody in the apocrine cells. These apocrine cells are also GCDFP15 positive, MACR positive, but I'm not going to go to talk about these other markers. Now, the first lesion when you talk about apocrine metaplasia in the breast is apocrine cysts. Apocrine cysts are very common. And in an autopsy series, they were found in nearly 50, a bit more than 50% of the women. They were observed between 27 years and 91 years, but they are most common between the ages of 30 and 50. It is often an incidental finding on your core biopsies or on your surgical specimens, but sometimes it can form a palpable cyst that will cause discomfort to the patients. Now, here are some examples of the apocrine cyst. In the upper right part of the slide, you can see cysts of varying sizes, and they are aligned by apocrine cells. This can either be apocrine metaplasia, you have a pseudostratified epithelium of apocrine cells, or it can form apocrine hyperplasia. Apocrine hyperplasia is when the apocrine cells proliferate and they form digitiform extensions into the lumen that are centered by small fibrovascular cores. This is called apocrine hyperplasia. Also, in some very large apocrine cysts, sometimes you will notice that the myepithelial cell layer may disappear in these large cysts. There are apocrine metaplasia is usually found, apart from the cysts, in sclerosing adenosis. This is what we call apocrine adenosis, and this can be confused with invasive carcinoma. I've seen a few cases of misdiagnosis of invasive carcinoma that were in fact apocrine adenosis. And of course, the immunohistochemistry here will be of great help to be able to recognize the myepithelial cell layer bordering these acini with P63 and CK14, for instance. And to define apocrine cells, we have the typical ER negative, AR positive phenotype. Also, sometimes in papillomas, you can see proliferation of apocrine cells forming micropapillae, that is devoid of fibrovascular stalks, and pseudocribiform structures. When you see this type of lesion in a papilloma, I would not consider this as a typical apocrine hyperplasia. I would just call this apocrine hyperplasia normal. This is just when it's in the context of a papilloma, but you'll see that the reasoning will be different when we find this type of proliferation in the surrounding breast tissue. I'm going to say I've got 2 slides on papillary apocrine lesions. This is an example of papillary apocrine hyperplasia, also called apocrine papilloma. These present as very large cysts where you have a proliferation of apocrine cells that form a monocellular layer around fibrovascular stalks. As you can notice on the slide, there are no apocrine atypia. And sometimes in these lesions, you can see also a disappearance of the myepithelial cell layer, as evidenced here with CK14 and P63. Notice that the apocrine cells of this phenotype ER negative and AR positive. Now, some people would argue that this is a papillary apocrine carcinoma because there are no myepithelial cells, but I do not agree with this. I think this is a true benign lesion, or at the most, a lesion of uncertain malignant potential. When you find this type of lesion on a core biopsy, we advise just surgical excision, just to be sure that this is a benign lesion, and that's all. On the contrary, here's an example of apocrine papillary carcinoma. As you can see, this is a larger lesion, a papillary lesion, and there are areas of necrosis and hemorrhage. And on closer view, you can see that the fibrovascular stalks are lined by a cell layer of apocrine cells presenting with high-grade nuclear atypia. These cells, again, here we do not see any myepithelial cell layer with the CK14, and the cells have a typical apocrine phenotype, ER negative, AR positive, and you have this granular cytoplasmic HER2 staining. Now, the differential diagnosis here would be papilloma with apocrine DCIS, but we would see, at least in some areas, the maintenance of the myepithelial cell layer. Also, another differential diagnosis would be with encysted papillary carcinoma, which is of low grade. But here, the cells are of high grade, and it's a triple negative lesion. So I would consider this type of lesion as a high grade encysted papillary carcinoma and manage in that way. Let's move on to atypical apocrine lesions. Atypia and apocrine lesions can be of nuclear type or architectural type. Concerning nuclear atypia, we would see in these lesions a variation in nuclear size from 1 to 3 with hyperchromatic enlarged nuclei exceeding twice the size of normal ductal epithelial cells nuclei. Architectural atypia would be a proliferation of apocrine cells forming micropapillary structures, cribriform or solid patterns often with preserved cellular polarity and rigid structures. Now, on the left here, you have an example of a typical apocrine adenosis. As you can see, the apocrine cells show nuclear atypia. And on the right, you have atypical apocrine hyperplasia with architectural atypia. So to make the differential diagnosis here would be with apocrine DCIS. So what you look for would be high-grade nuclear atypia or tumoral necrosis or an extension of more than 3 millimeters. Now, these criteria may be difficult to apply when you're considering a core biopsy. And this is an example here of a typical apocrine adenosis. And you can see the apocrine cells have nuclear atypia. Well, in this case, what helped us make a diagnosis of apocrine DCS was the cells overexpressed HER2 with a 3+ score. And this happens in approximately 50% of apocrine DCIS. So this is a nice thing to know when you're considering differential diagnosis between atypical apocrine adenosis and apocrine DCIS. So how do we manage atypical apocrine lesions in core biopsies? Unfortunately, there are no specific guidelines to my knowledge. The decision to proceed with surgical excision should be guided by the nature and extent of the atypia identified in the biopsy and radiological and pathological correlation. I found one study involving 15 atypical apocrine lesions identified by core needle biopsy of ultrasound detected masses. And in this study, they reported an upgrade rate to apocrine ductal carcinoma in situ or invasive apocrine carcinoma in 25% of cases. So the take-home message here would be that the identification of an atypical apocrine lesion on a core biopsy of a mass, and I insist on the term mass, warrants a surgical excision of the involved area. So let's move on to apocrine carcinoma in situ. So is there a specific apocrine cancer pathway starting from apocrine metaplasia to invasive apocrine carcinoma with intermediate steps such as atypical apocrine hyperplasia and apocrine carcinoma in situ? Well, to say, I think there is a specific apocrine cancer pathway because there's a common immunoprofile, ER negative, AR positive between all these lesions. And there were common genetic lesions, at least between apocrine carcinoma in situ and invasive apocrine carcinoma that were found, in particular in the study of Jones and Schwartz. So apocrine carcinoma in situ can be of ductal or lobular type. Concerning apocrine DCIS, it's a rare variant of DCIS, and there are no specific clinical or radiological features concerning this lesion. When we consider apocrine DCIS, sometimes it's difficult to give a nuclear grading because if you use the usual nuclear grading according to the Philadelphia 1997 consensus conference, it's difficult to apply in the context of apocrine DCIS because de facto the apocrine cells have larger cells than normal epithelial cells. In 2001, a group from Vanderbilt studied a series of 35 cases, and they devised a new grading system for apocrine lesions. And in their series of 35 cases, they found that 43% were of high grade, had high-grade nuclear atypia, 54% were of intermediate grade, 3% were of low grade. Tumor necrosis was present in 70% of cases, and in approximately 50% of cases, there was a 3+ overexpression of HER2 in these lesions. And in up to 71% of high-grade apocrine DCIS, there was overexpression of HER2. So here are some examples of apocrine DCIS. This is a core biopsy, and as you can see, we see this atypical apocrine proliferation on all the core biopsy fragments. And I would consider this as a low-grade apocrine DCIS. There is no necrosis, and There are low-grade apocrine features. Well, the diagnosis of DCIS was confirmed on the surgical biopsy, but one could argue here with a typical apocrine hyperplasia. Here's an example of a apocrine ductal carcinoma in situ of intermediate grade. As you can see, there is some necrosis with intermediate grade nuclear atypia, and we have the typical apocrine immunoprofile of ER negative and AR positive. Here's an example of a high-grade apocrine ductal carcinoma in situ, high-grade nuclei. And again, we have this ER negative, AR positive phenotype. We have 3+ overexpression of HER2, and the tumor cells do not express high molecular weight cytokeratins. Another example on a core biopsy of an atypical apocrine proliferation with a differential diagnosis between atypical apocrine adenosis versus apocrine DCIS. And as you can notice, there was a 3+ overexpression of HER2 in the tumor cells, so we concluded to apocrine DCIS. What about apocrine lobular carcinoma in situ? So this is an intraepithelial proliferation of non-cohesive cells displaying a morphological and immunohistochemical apocrine features. There are sparse data, all published series. When you read them carefully, you find that there's the mixture of true apocrine cells and ER-positive pink cells. Anyway, these apocrine lobular carcinoma in situ occur most often in postmenopausal older women. They are frequently associated with calcified necrosis detected by mammography. They can be of pleomorphic or florid type lobular carcinoma in situ. In the series of Shamir et al., they were associated with invasive carcinoma in 77% of cases. And when diagnosed on core biopsies, the upgrade rates on surgical specimens varied from 17 to 25% in the series of Cuba et al. Here's an example of an apocrine lobular carcinoma in situ, what the WHO, the current version, would call the apocrine variant of the pleomorphic lobular carcinoma in situ. And as you can see in the upper images, we have areas of necrosis in this proliferation, and also we have calcifications. These type of lesions are typically detected by microcalcifications. And on close-up, you can see that these are non-cohesive cells with apocrine-like features, and they're of course E-cadherin negative, ER positive, and androgen receptor positive. Now let's move on to invasive apocrine carcinoma. Invasive apocrine carcinoma, it's a rare tumor. It represents less than 1% of breast carcinomas. And here is the class. On this slide, I represented all the different types, histological types of triple-negative breast cancers. So apocrine carcinomas represent less than 5% of TNBCs in our series. TNBC representing 10% of all invasive breast carcinomas in a survey that we did on 5,000 invasive carcinomas in our institute. So apocrine carcinoma, anyway, the triple-negative form of apocrine carcinoma is a rare lesion. There are no distinctive clinical or radiological features compared to invasive NST carcinoma for apocrine carcinoma. They occur most often in postmenopausal older women. The data on invasive apocrine carcinoma are somewhat imprecise. It's due to problems in definition, as I already mentioned. These tumors can also be ER negative or HER2 negative or HER2 positive. And also there's a disagreement of the ER positivity threshold. In France, it's 10%, and in the US, it's 1%. Anyway, the WHO 5th edition gives essential and desirable criteria for making this type of diagnosis. It's essential that the tumor cells must have apocrine morphology in more of 90% of the population. And desirable criteria, the tumor cells must be ER negative, PR negative, and androgen receptor positive. When you consider that these tumors are smaller and more often Nottingham grade 1 or 2 compared to invasive carcinoma NST, they are frequently associated with apocrine DCIS. These type of tumors do not respond well to neoadjuvant chemotherapy. There's no PCR that was found in the series of Schwartz et al. This type of lesion. All lesions were classified as RCB 2 or 3. And however, there are more favorable outcomes for triple-negative apocrine carcinomas compared to basal-type triple-negative breast cancer. So let's look at the grading of these invasive apocrine carcinomas. Now, this is an example on the left of grade 1, on the right upper image grade 2, and then grade 3 on the bottom image. In the series of Schwartz et al., most of the apocrine carcinomas were Nottingham grade 2, 80% in their series. And then afterwards, there were 17% that were grade 3 and 3% that were grade 1. So, although they are ER negative and PR negative, invasive apocrine carcinomas display a luminal phenotype, meaning that they are androgen receptor positive, FOXA1 positive, and FOXC1 negative. They show a heterogeneous HER2 expression, with approximately half of them being HER2 low, that is 1 plus or 2 plus HER2 non-amplified, the rest being HER2 positive, that is 3 plus or 2 plus HER2 amplified. Also, in these type of lesions, there are low levels of TILs, 10% of TILs and 93% of the series of Gaetan et al. The median Ki67 expression is at 10%, with nearly 90% of tumors Ki67 being less than 20%. Sometimes there's a focal weak positivity with CK56, but CK14 is always negative. SOX10 is negative compared to basal type triple-negative carcinomas. TRPS1 can be negative or may show focal weak expression in opposition to the majority of other subtypes of breast cancer that are strongly and diffusely TRPS1 positive. GCDF-15 will be strong in expression and diffuse, and MACR will also show a strong diffuse expression. So, concerning HER2 expression, invasive apocrina can be considered as a Janus tumor, a tumor with two faces, half of them being HER2 negative and half of them being HER2 positive. Now, the spectrum of HER2 expression in invasive apocrine carcinoma is pictured here in this slide. There's a recent paper by Chinese group Xiao et al. In clinical breast cancer, where they studied 74 cases of apocrine carcinoma, and 9% of the cases they were score HER2 score 0. In 16% of cases, there was HER2 score 1 plus, and 34% there was HER2 score 3 plus, and then 41% they were score 3 plus. They noticed also using the 4B5 Ventana HER2 antibody cytoplasmic granular staining in 35% of cases, mainly in HER2 low cases. And when they compared this pattern of staining with the pattern obtained with the Agilent A0485 clone, the granular cytoplasmic staining was only found in 12% of cases. So I do not know if this is an artifact, is this a problem with specificity of the 4B5 antibody, or does it really attach itself to something very meaningful in the apocrine cell, in cytoplasm of the apocrine cells? Well, the other face of the apocrine tumors is the group of apocrine HER2 negative tumors. Well, I can see this is an example here that is PR negative, androgen receptor positive. It shows a HER2 low or ultra low expression. It's FOXA1 positive, FOXC1 negative, and GATA3 positive. There are not many studies that study the molecular genetics of invasive apocrine carcinoma. This is a resume of what I found. There's no association with germline BRCA1 or 2 mutations. There may be a predisposition to do invasive apocrine carcinomas and Cowden syndromes with a germline P10 mutation. There's a low tumor mutational burden, no microsatellite instability, no genomic instability. That means few amplifications and deletions. There are frequent PI3K pathway alterations concerning PIK3CA or P10, and there are rare TP53 and RAS MAPK alterations. So I'm going to move on now to the molecular apocrine tumors concept. And the term molecular apocrine tumors was defined when we performed the study in 2005. It's more than 20 years ago, and we had a small group of nearly 50 breast cancers that were we analyzed the transcriptome of these 50 breast cancers, and we analyzed the transcriptome by non-supervised clustering analysis. And this form of bioinformatical analysis does not take into account the HER2 status of the tumors, contrary to the intrinsic classification of Sorley and Peru. Anyway, using our non-supervised clustering analysis, our 49 tumors could be divided in 3 classes. The first class was ER positive and androgen receptor positive, and we call them luminal type tumors. The second class was ER negative and androgen receptor negative, and we call this basal type tumors. And finally, the last class was ER negative and androgen receptor positive. The morphology of this third group, the ER negative, AR positive group, the morphology of the tumors resemble more or less to apocrine tumors. That's why we call it molecular apocrine tumors. Now, how does this transcriptomic class of molecular apocrine tumors compare to the other current molecular classifiers? Well, if you compare it to the intrinsic classification of Sorley and Peru and the PAM50 signature, our molecular apocrine tumors, either HER2 negative or HER2 positive, all belong to the HER2 enriched class of the intrinsic classification. When you look at the molecular apocrines that are HER2 clinically negative, and so they are triple negative, they're considered triple negative, and when you compare them to the other triple negative classifications, the one of Lehmann, the one of Bernstein, and the one of Jiang, the molecular apocrine tumors all that are HER2 negative belong to the luminal androgen receptor group. So, considering the molecular apocrine tumors that are HER2 3+ or 2+ amplified, as I told you, they belong to the HER2 enriched class, according to Sorley et al., and more recently, they belong to the HER2 amplified class, according to Gaetan et al. Before the advent of the anti-HER2 drugs, these tumors had a very poor prognosis. This is, if you look at the Kaplan-Meier on the right of your screen, you can see this is the MetaBrick study, where they studied different molecular classes of tumors, and the brown curve corresponds to our HER2 enriched tumors with amplification of HER2. And before the advent of anti-HER2 drugs, they had the poorest prognosis in breast cancer. However, with the advent of anti-HER2 drugs, these HER2-enriched tumors are very sensitive to these drugs, and in fact, they respond better to anti-HER2 drugs than the luminal B HER2-positive tumors. This was you can see this at the bottom right of your screen here with the PCR rate of the HER2-enriched class of HER2-positive tumors compared to the luminal tumors that are HER2 positive, and you can see that the PCR rate is practically double in the HER2 enriched class of tumors. Now, when you study these HER2, when you study these HER2 enriched tumors, well, you realize that only 50% of them are HER2 amplified. And Demon et al., who studied a bit more of these tumors at the point of view of their transcriptome, found that they all HER2 enriched tumors display high levels of androgen expression and androgen receptor dependent genes, as you can see here at the bottom left of your screen. So here's an example of an invasive NST, HER2 positive of the HER2 enriched subtype. As you can see, it's ER negative, strongly AR positive, and it shows a 3+ staining with HER2. Now let's move on to HER2 clinically negative molecular apocrine tumors. As I told you before, they belong to the luminal androgen receptor class of TNBC. And here, this is the study of Bernstein et al. I took the heat map of the Bernstein et al. Study, and you see the LAR, the luminal androgen receptor group of tumors. They are at the extreme right of this image, and you can see that there is underexpression of proliferation and DNA repair genes in this set of tumors, of LAR tumors. There is overexpression of androgen receptor-driven genes, such as androgen receptor, of course, but also SPEED-F and the gene that codes for GCFP, GT15, it's PIP. There's also overexpressions of genes also overexpressed in ER-positive tumors, such as FOXA1, GATA3, and low molecular weight cytokeratins. What about point mutations in LAR tumors? There is a higher frequency of point mutations compared to other triple-negative breast cancers for PIK3CA, KMT2C, NF1, AKT1, and CDH1. So as akin to what was observed for the invasive apocrine carcinomas, you can see that the LAR tumors have a high frequency of PIK3CA mutations, and also of interest, there's quite a high rate of CDH1 mutations in these tumors, CDH1 coding for ecadherin. I'll come back to that later on. Concerning copy number variation, DNA copy number variations in LAR tumors, there is less genomic instability in LAR tumors compared to other triple-negative breast cancers, with a higher frequency of gains amplifications for EGFR and AKT1, and a higher frequency of deletions for different sets of genes, such as TP53. So here's an example of an invasive NST TNBC of LAR subtype. As you can see, the tumor cells are ER negative. They're in fact ER low, considering the American standards. Anyway, considering the French standards, the threshold of positive cells is less than 10%, so we would call this ER negative. They are AR positive, HER2 negative, FOXA1 positive, and FOXC1 negative. Here's an example of an invasive lobular carcinoma, pleomorphic subtype, triple negative, and also of LAR subtype. And of note, 95% of triple-negative invasive lobular carcinomas will display a LAR phenotype. This we found in another study that was published some time ago. And you can see here, pleomorphic invasive lobular tumor that is ER negative, strongly AR positive, FOXA1 positive, and FOXC1 negative. So as you can recall, 13% of LAR tumors show a mutation in the CDH1 gene. So how do we apply this concept of molecular apocrine tumors in clinical practice? Well, these concern ER-negative tumors, and there's a spectrum of lesions that will go at one end from low androgen receptor positivity, variable expression of FOXA1 and FOXA1, and this is found mostly in NST and invasive lobular carcinomas. And at the other end of the spectrum, we have tumors with a high expression of androgen receptor at 100% positive cells that are FOXA1 positive and FOXC1 negative, and this is mostly correlated to an apocrine morphology of the tumors. So in clinical practice, HER2 positive molecular apocrine tumors, well, we've got the solution to treat them. As I told you before, they are very sensitive to anti-HER2 therapy. On the other hand, HER2 negative molecular apocrine tumors, the LAR tumors, represent at the moment an orphan disease because there are no real specific effective therapy in this type of lesion. So we're going to, the next slides, we're going to talk about the LAR tumors, the triple negative luminal androgen receptor tumors. And in this study by Thompson, they looked at the PCR rate of the LAR tumors compared to other triple negative breast cancers. And their conclusion in this study was that large tumors achieve less often PCR compared to other TNBC. In advanced breast cancer, when the patient is metastatic, there are not many options to treat these patients, and there were a few clinical trials these last years that were testing androgen receptor hormone therapy in this class of tumors, given the fact that they overexpress androgen receptor and they appear to be under the influence of the androgen receptor pathway. People thought, well, let's try and treat these patients like we would treat prostate cancer, and give them hormone therapy like we do like in prostate cancer. Well, the conclusion of these 5 trials was that the benefit of anti-androgen receptor hormone therapy in advanced breast cancer for luminal androgen receptor tumors is limited using an immunohistochemical cutoff for androgen receptor at 10%, with clinical benefit rates ranging from 19% to 28%, which is pretty low when you consider the targeted therapy in advanced breast cancer. Anyway, we published two clinical trials. With one clinical trial, we tested darolutamide, which is an anti-androgen drug. It was the START trial, and we found that in the START trial that the patients with the greatest clinical benefit rate exhibited a molecular apocrine transcriptomic profile by transcriptome with activation of the androgen receptor pathway. And also using an androgen receptor immunohistochemical cutoff at 80%, the clinical benefit rate also was elevated. It was at 47% compared to the 10% threshold that we used for the trial. And also using an androgen receptor immunohistochemical cutoff at 10%, some large tumors defined as LAR with an AR cutoff at 10% displayed by transcriptome a basal type transcriptomic profile. In another trial that we performed using abiraterone in advanced breast cancer, we found that all the patients that had a clinical benefit from this drug had a apocrine score that was high. How did we define this apocrine score? We call it IHC4 apocrine score. It's a score that we made up using the percentage of androgen receptor positive cells, a H score for FOXA1, a H score for GGT1 and GCDFP15. These last two proteins belong to the androgen receptor pathway. And if this HC4 score was superior to 800, all the responders in the series had an HC4 over 800, and also they had apocrine morphology. So I've got 2 or 3 minutes left for my talk, and I got 3 slides left. So I would just like to talk to you to finish my talk about the interactions between the estrogen and androgen receptor pathways and the HER2 and androgen receptor signaling pathways in molecular apocrine tumors. Considering ER and AR, well, different molecular analyses have found systromic sequence homologies for ER and AR, meaning that there are genes with promoters of different genes that are common for estrogen receptor and androgen receptor, as you know, that are nuclear transcription factors. Also, FOXA1 sites, FOXA1 fixation sites are enriched in AR binding sites. And also, these molecular studies found that ER regulated genes are also regulated by androgen receptor, meaning that the androgen receptor pathway and the estrogen receptor pathway are highly intricated. On the other side, when you look at the interaction between androgen receptor and HER2, different preclinical studies found that HER2 expression in the cell lines was induced by androgen, in particular dihydrotestosterone. Androgen expression is also induced by hereglin, and androgen receptor inhibitors also inhibit expression of HER2. there again, there is a close, intricate connection between the androgen receptor pathway and the HER2 pathway. And also, I've spoken a lot about FOXC1 and FOXA1 in this talk. Well, again, FOXA1 and FOXC1 are nuclear transcription factors, and they share common DNA targets. FOXA1 is overexpressed in luminal breast cancers and in LAR TNBC, and underexpressed in basal type TNBC. On the other hand, FOXC1 is underexpressed in luminal breast cancers and overexpressed in basal type TNBC. So these two factors are inversely correlated, FOXA1 and FOXC1. So a FOXA1 positive, FOXC1 negative phenotype is useful for defining LAR subtype and more broadly the luminal phenotype, whereas a FOXA1 negative, FOXC1 positive phenotype is useful for defining the basal subtype. So my concluding remarks is that, well, the mammary gland is an evolved form of a primitive apocrine gland in the phylogeny of the mammal species. Apocrine differentiation is the result of ER inhibition and AR activation. The spectrum of apocrine breast lesion is extensive, as I've shown you. It goes from apocrine metaplasia to invasive apocrine carcinoma. Apocrine carcinoma belongs to the molecular apocrine class. It's at the higher end of the spectrum. The molecular apocrine class includes HER2-enriched tumors and LAR tumors. LAR tumors represent an unmet therapeutic need. Anti-androgen hormone therapy appears to be effective in LAR tumors displaying androgen receptor pathway dependency. Thank you for your attention.